Okay, I think we're ready to get started.
Speak slowly.
Welcome to Politifest 2025. If this is your first session, if not, welcome to your second session of Politifest. It's great to be here with you today. In case you're not familiar with us, Voice of San Diego is a nonprofit investigative news organization committed to holding public officials accountable and giving you, the public, the information you need to be advocates for good government. As a nonprofit, we depend on members, donors, and sponsors like you to make our work possible. Thank you for your support. I'd like to take a minute to recognize our sponsors who help make Politifest possible. A special thanks to the College of Arts and Sciences at the University of San Diego for being our partner for the 8th year. Our thanks also to the Sequan Band of the Kumeyaay Nation, Mark Nelson and Nelson Stakeholder Consulting, the San Diego Foundation, Hidsky Development, and Tessa, the Previs Foundation, First 5 San Diego, and AARP. We'd also like to recognize KPBS and iNewsSource, our partners in Public Matters. We are partnering to share content, conversation, and events like Politifest to ensure all San Diegans understand their opportunity to participate in the democratic process, and it means more than voting in an election. Other side of the page here. Okay. Today, there are over 1,000 Price Fellows. I think this might actually, I'm sorry, guys. I have all my pages messed up. I was just moderating a panel. I was running from thing to thing a little bit today. But one thing that we do want to point out is the model is a little bit different this year. When it comes to the end of this panel, you're actually going to be voting on who you think has the best solution. And so you'll be using this QR code here, and that will pop up. And if you want to take a look at that now too, if you might have any questions during the panel, you can use the app to ask those questions. So we'll be putting this up at different points in the panel, but if you want to log on to that now. Also, we will have note cards as well. So if you're having any issues with the app and you have a question, raise your hand. We'll be looking around and seeing if anybody's having some issues. And also, I'm more than willing to sit down next to you and help you with the app if you have any issues. Now, without further ado, I would like to introduce our moderator, Jim Hinch, who is our South County reporter at Voice of San Diego.
Hello, everyone. As Lisa said, I'm Jim Hinch, South County reporter for Voice of San Diego. I think we can all agree, that's probably why we're all here, that behavioral health issues are some of the most complicated and challenging issues facing San Diego now. I think behavioral health is also an issue with which a lot of people have a personal connection. Even if people don't struggle with a behavioral health issue themselves, they often know someone who does, or know someone who knows someone who does. The subset of the population that struggles with behavioral health issues that we're talking about today are sort of one of the most visible facets of the problem. These are usually are folks who are badly in need of treatment, but often say no when offers of treatment are made to them. And they are often the people that you see on the streets of San Diego. I think it's fair to say that the San Diego region has not done a good job with this population. Just over the past 5 years, from 2020 to 2025, the number of unsheltered homeless people, that is the people that you see on the streets, has jumped from about 3,900 to 5,700. And that's despite hundreds of millions of dollars being spent and repeated pledges from elected leaders to address the problem. Part of the problem here is that there are many different competing theories for the best way to address this problem, and there are many agencies and overlapping layers of authority addressing the problem. I think it's fair to say that most parts of this system do not coordinate well with one another and are not all pulling in the same direction or moving together on a unified strategy. So one of the purposes of conversations like this is to try to bring different facets of this kind of vast care system together and get them all moving in the same direction. Today, we're going to hear from several leaders on this issue. We were going to hear from 3 leaders on this issue, but one of them, for various reasons, has not been able to make it today. So we're going to hear from 2 leaders on this issue, sort of each of them with different proposals for making this system work better. The first of our presenters is Paul Armstrong. He's Chief of Staff and Vice President of the San Diego Rescue Mission, which is a faith-based organization that believes in a community-based 12-step long-term recovery process and operates a network of shelters and treatment programs throughout San Diego County. And then we're also going to hear from Dr. Meyer. He's a professor of psychiatry at UCSD and the behavioral health officer for the city of San Diego. We were also going to hear from Stamos-Buesig. She's the founder and CEO of the San Diego Harm Reduction Coalition. She was going to make a case for sort of a harm reduction oriented approach to solving this problem. Unfortunately, we won't be able to hear from her, but maybe our presenters can nod in some cases to sort of that philosophy or approach to solving this problem. The way this is going to work, each of our presenters will have about 10 minutes, but maybe a little longer now, since there are only 2 of them, to advance a solution. And they'll kind of have the floor for 10 or maybe, 10 to 15 minutes. And then I'll moderate a discussion between them in which they kind of talk back and forth. And then at the end, when we have about 10 or 15 minutes left, folks in the audience will have a chance to ask questions. And then you all will have an opportunity to vote on the solution that you think would be most effective for improving conditions here in San Diego. So without further ado, I will turn the floor over to Paul, and Paul, take it away.
Well, thank you, everyone. And I just want to start by, when we did the pre-meeting for this and I got to meet Aaron, I'm like, holy cow, this guy's really smart. So I'm just like, okay, I really had to up my game. I hope I did. But I just want to say, and in today's political climate, it's kind of nice to have just a good old-fashioned conversation about the issues where we can respect one another. And I'm going to tell you, I have a lot of respect for him, for the ideas he's going to bring. Please vote for me, though my ideas are just a little better. Yeah. Hey, I want to look at this issue. I want to look at this issue in 3 ways. I want us to think about it culturally, clinically, and then personally, and then I want to offer some solutions. So first, from the cultural perspective, right, we got to acknowledge that we live in a very individualistic culture. If we were in a more communal culture, we would have a higher responsibility for how we cared for one another. But instead, we are in America where we're not just individualistic, we're hyper-individualistic. And don't you dare tell me what to do, right? And the consequence that we're seeing is that actually we're becoming more isolated and disconnected. And the consequence of being more isolated and disconnected is people are falling through the safety net at a higher rate. So you got to think of it, as I thought through the safety net, think of it 2 types, our personal safety net and our societal safety net. The societal safety net is our not-for-profits and our government. That's when I have to step in. The personal safety net is people's families, friends, their own personal resources. And because that is being deteriorated, now we're going to have to think of how do we want to respond as a community, and is there a responsibility that we have for one another that's at a higher level? On the clinical side, our 2 buzzwords in this industry are person-centered and evidence-based practice. Can I get an amen? Everything. Now, when I was getting my MSW, what we were doing is we were actually working on, we would be given a case, and then we'd have to go and find 2 or 3 evidence-based practices that would work for that particular individual. What we've seen now is that we've taken kind of one evidence-based practice and said that that's the only solution. In other words, one size fits all. That's not actually being person-centered. So I'm going to tell you right now, so nod to Tara, harm reduction is an evidence-based practice. There are times and places to use harm reduction, but we can't let that be our only practice. because that's going to miss out on opportunities to help everybody that we're having to see. And this really shows up in how the care is actually delivered. Okay, I have a huge respect for the frontline staff. So I'm in homeless services. My frontline staff are amazing and they hustle. And I wake up every day going, am I hustling as hard as my frontline staff? And why are they hustling? Because they're trying to get people connected to behavioral health services. And as they try and get people connected to behavioral health services, the most common refrain we hear is, they said no to services. Of course they said no to services. They think they're the king of England. They're delusional. They are not in a good place and they're going to refuse services. So they get passed over. And because of supply and demand, for that one no, there's 10 people waiting in line. And so the behavioral health system is able to serve whoever is, they can say yes. The consequence, our most needy people are left out on the streets. And we see this every day, trying to get people connected. And now I'm going to tell you a dirty little secret. We do then force people to get treatment. We just wait for them. I heard this term. Our system is a system where you have to fail up. We simply wait for people to do something so bad that they either end up in jail or they end up hospitalized and can't be released. And this is not hypothetical. Just last week, my outreach team, we were talking and they're like, hey, one of the people that they're working with, mental health issue, SMI, could be solved with taking medication, refuses to take medication. Hey, I have good news for you. That person's getting off the street. They know it. They're like, yeah, we're probably going to go. We think he goes to court next week and we'll go away for a while. Yay, we solved homelessness. We're sending him to jail. Yeah, we should be ashamed. That's our reality. That's our reality. Now, again, when we think of it, I'm thankful for Narcan. Narcan is so helpful. It's saving lots of people's lives, right? Here's again the consequence. It reduces overdose, but it doesn't eliminate it. And our bar of success is that people didn't die. Maybe we should have a higher bar of success. And the reason we're okay with that, and now to shift to my personal, is because, well, at least it wasn't my son that overdosed. At least it wasn't my sister that overdosed. When you talk to people, right, that's the reality is people want tools when it's their family member, when it's a personal connection. And let's face it, we all live with constraints relationally. How many of you ever heard, if you don't change, you're sleeping on the couch? We have people in our lives, and many of us do have people who have substance use issues, mental health issues. And we honor when they said, yeah, I had to set a firm barrier. I had to say, you had to take your medication if you're going to continue to live here. And we honor that in the personal safety net. We need to figure out what that looks like in the societal safety net so that we can make sure that people are getting connected to the services that they need. And I can't tell you how many times, and again, we shouldn't be okay with this. I hear from family members, I'm so glad they were arrested. Because at least they won't be using for a couple of days. I've heard from people who have then gotten help saying the best thing that ever happened to me was I was held accountable. And so we got to acknowledge that and maybe move the bar so we're not waiting for it to get to that level before they're getting the help that they need. So what can we do? First and foremost, we got to demand a dynamic by name list of the people experiencing, and I'm going to talk specifically about people experiencing homelessness. Aaron and I have two different lists. We both work with people experiencing homelessness. I have my top priority. He has his top priority. Are we working together? No. We need a dynamic by name list that then results in actual care coordination where we're working together with the highest needs people getting addressed first. And it's great. If you have a by name list, I have my top 10 and I'm working the top 10. Push the issue around that care coordination. This is one area where we really got to up our game in CalAIM. So those of you who are familiar, Medi-Cal allowed for CalAIM efforts to come to community-based organizations. So community-based organizations can be tapping into medical resources, right? It's the integration of the medical system with the homeless service system. We kind of suck at that in San Diego County right now, but the model is there. Let's just actually use the model. And then are there other models where we've actually required people to get help? Actually, the drug court is a phenomenal thing. If you don't know what the drug court is, it basically is where you properly leverage consequences for people who had drug offenses so that they were incentivized to do treatment over the judicial system. This is a proven practice. This works. You know what it helps with? Well, it actually does reduce crime. It actually increases treatment. It actually saves taxpayers' dollars, and it ensures coordination because this is now court mandated. It's required. Now, how many of us got super excited when we heard about Care Court? What if we just did what was advertised? What Care Court promised us was that actually we were going to lower the requirements to make it easier to push people into treatment who are saying no. And instead, we're still keeping it voluntary. We're narrowing the scope of it. And so between kind of the combination of what we know works in drug court and with what the intent was behind Care Court, we actually are a good way there. And finally, just in San Diego, we got to stop loving pilot projects and actually scale things. Hey, did anyone hear how it went to have behavioral health services integrated into the city of San Diego's Rosecrans shelter? Neither did I. Okay, so what we did is we actually had a city-county integration where they put county behavioral health into a city-run shelter. Sounds great. I wonder if it worked. I will tell you again that integrating those services, I'm having to struggle. So I'm a shelter provider. I have to negotiate to find a behavioral health person who will come to my shelter. And then to get them to stay, well, if it's a county contracted one, not for long. And so, right, we have these concepts. We've done pilot projects. We now just need to actually raise up the bar and actually raise them to scale and do it. As a shelter provider, it should be a no-brainer. I should have behavioral health providers lined up to come to my shelter. I should not have to be the one going to find them. And that goes back to that care coordination. And if I had a dynamic by name list where I was requiring care coordination, where I was doing the best practices of both drug court and care court, wow. But ultimately, it's going to take one thing. It's going to take us actually saying we all have a part of this, that it's responsibility. So if everyone wouldn't mind repeating after me, I am responsible. There you go. Thank you. And it's enough.
Been waiting years for this talk. So I am Aaron Meyer. I'm a psychiatrist at UCSD. I also work with the city of San Diego. I'm not speaking on behalf of either, in case anyone from the city or UCSD is here. I'm not speaking on behalf of either. But I am speaking on behalf of someone who sees patients in emergency departments, on hospital floors, in outpatient clinics, in people's homes, and on the streets of our city. I am speaking as someone who sees people languish and sometimes die despite enormous amounts of healthcare. People who have been in and out of emergency rooms hundreds of times, who cycle through jail, who live unsheltered. They are visible to all of us, yet invisible in terms of spoken solutions. That's why I believe this question demands prioritization. This question deserves a comprehensive vision. And I am so grateful to Voice of San Diego for providing this opportunity. And I'm fortunate to sit with Paul, and I wish I was sitting with Tara, who are also part of this, the solution. But I want to start with a guiding principle. Every person is uniquely complex. A person is not just a set of diagnoses. A person is not just a collection of behaviors. Refusal of treatment doesn't come out of nowhere. It can come from experiences, from trauma, from mistrust, from cognitive conditions that affect someone's ability to choose. So when we ask why someone refuses treatment, we have to zoom out. We have to ask, what has this person lived through? What abilities or impairments shape their choices? Refusal is never just refusal. It's a symptom of something deeper. So today, I want to focus on One thing, on a small but very visible group of people who are chronically gravely disabled. So these are individuals with severe mental illness or severe substance use disorders who are unable or unwilling to provide for their basic needs. They can be the people you see sleeping on the sidewalk. They can be people who are housed with their families who are struggling with them. They can be people who are wandering from emergency room to emergency room. These individuals have a family. They are someone's son. They are someone's daughter, sister or brother, mother or father, and they deserve our care. They are a small group, but they account for a large share of suffering, and they are often the people most likely to preventably die in our communities. So how do we respond as a county? I believe there are 5 areas where we can make meaningful changes. First, when people are ready for treatment, even if they've refused for months or years, we must be ready to say yes. In Los Angeles, their county agency has created a service and bed availability tool. It's like a real-time dashboard of every substance use disorder treatment bed in the county, with filters for wheelchair accessibility, weekend intake, or specialized populations. The best part is that it shows you if a treatment bed is available. Imagine if San Diego had something like that. Let's also make sure San Diego prioritizes the most vulnerable with the most significant needs by showing the public where we are and where we need to go. So let's measure what matters. How many hours do people spend waiting in ERs before they get to where they need to go? How quickly can someone transition to a less restrictive setting when they no longer need hospitalization? For each type of bed, whether it's inpatient psychiatric, chemical dependency recovery, detox, or rehab, how many beds do we have and how many beds do we need? If we build a public dashboard for these metrics, we will not only hold ourselves accountable, we will send a clear message that these lives matter. Second, we need to stop excluding people simply because they don't fit neatly into a box. Right now, people with both autism and mental illness often get care for neither. People with dementia or traumatic brain injury who exhibit psychiatric symptoms are told they don't qualify. Even people with severe substance use disorders who are gravely disabled may be turned away. This is what I call system refusal. The patient isn't refusing us, we are refusing them, and it is unacceptable. We need to reform our practices so that people with complex needs are preferentially included, not preferentially excluded. Our system must acknowledge that complexity is the rule, not the exception. Third, let's talk about 5150s. So this is a tool law enforcement or county designated professionals use when someone is a danger to themselves, danger to others, or gravely disabled. This intervention allows an individual to be held over their objection in a treatment setting for a period of up to 72 hours. So recent legislation, as many of you are aware, expanded the definition of grave disability to include those with severe substance use disorders or those who are unable to provide for their own necessary medical care. But here's the problem. Law enforcement and crisis teams don't have access to medical records. They don't always know the whole story. San Diego should do what other counties have done, multiple other counties have done. We should expand 5150 authority to specially trained paramedics. They have medical knowledge and crisis expertise, and most importantly, they have access to the person's medical record. So that this way, when someone is clearly unable to survive safely, we can respond in a more informed and compassionate way. Fourth thing, we need to operationalize the 5200 process. How many of you have heard of Welfare and Institutions Code 5200? One person, two people who I know. But most people, like those in this room, have never heard of it. But 5200 is supposed to be the path for individuals who are chronically gravely disabled. This intervention allows for a court-ordered psychiatric evaluation. It is fundamentally different than the 5150 process. Families Outreach workers and first responders should be able to request this statutorily required investigation when someone is clearly in long-term danger. But in practice, this process is nearly impossible to access. Counties rarely act on it, and so families are left with nowhere to turn. So we must create a clear, transparent way for the public to request 5,200 investigations for their loved ones and for the county to fulfill their duty, so this law can serve the people it was written for. Finally, we need to learn from other counties, particularly when it comes to conservatorship. So conservatorship is an intervention that should only be used when everything else has failed. It is meant for people who are gravely disabled, who cannot manage their basic needs. But right now, mental health conservatorship referrals in San Diego can only come from hospitals. But many chronically gravely disabled people never meet inpatient criteria. Why? Because when they come in, it said, oh, they're at their baseline. Well, if their baseline is chronic grave disability, it's unacceptable. And so we need alternate pathways. So in the absence of alternate pathways, people like this cycle endlessly between the ER, jail, and the street. In the absence of an alternative pathway to conservatorship, hospitals become the unwitting barrier between the person who desperately needs help and the county agency responsible for providing that help. Other counties have found better ways. Los Angeles's homeless outreach and mobile engagement program, HOME, allows outreach teams to initiate conservatorship referrals directly from the street, and it works. San Diego should follow their lead. We could invite HOME to present their model and begin building our own outpatient referral process. Hospitals cannot be the only gateway to conservatorship. So let me close with this. We have built a system of care for people who keep appointments. We have built a system of care for people in acute crisis, but we have not yet built a system for people in chronic crisis, those who are too sick, too impaired, or too lost in illness to care for themselves. These are not simply people who refuse help. These are people for whom help has not been structured in a way they can receive. If we are serious about addressing treatment refusal, then we must be serious about building a system that refuses to give up on them. Thank you.
So we will move now to the debate/conversation part of this. I want to say that we did get a message from Tara. I guess her flight came in a little earlier than expected. It looked like she was having airport problems and would not be here. She may actually come bursting in at an opportune moment, in which case I think we'll sort of stop for a minute and we will give her 10 minutes to make her spiel, and then we'll sort of try to integrate her into the conversation. But for now, what's that? Right. Just wanted to remind you, as you're thinking about the questions that you yourselves want to pose to our panelists, you can call up the app and be writing those in. If you're having trouble with the app, you just raise your hand and a volunteer will give you a note card and a pen, and you can write your question down that way. So I think I'll start off with a question for Paul, but it's really kind of a question for both of you. Paul, a lot of the fixes or changes that Aaron was talking about involve changes to public agencies and public laws. And one component of the system that I really didn't hear him mention a lot were private organizations, privately funded or nonprofit organizations that aren't necessarily connected to a government agency such as yours. And I wanted you to have an opportunity to say kind of what role you see for those organizations in this system.
Yeah, absolutely. So I think this is where one of the, yes, we're primarily privately funded, but we play within the sandbox. So we're integrated and we're in the homeless service system. We're a part of the continuum of care. We're a part of that. And that's why I would be more of the advocate for that by name list, because that's something we can all contribute to. So we can show up to the table. And I promise you, if some of the reforms he was talking about, our outreach workers would totally, however it needed to be. Like when our outreach workers go out there, okay, again, here's how because we tend to rely on our justice system. Our outreach workers go out with sheriff. I would be happy to go out with a home team. Our outreach workers have the opportunity to build the relationship. And so, yes, as a private organization, we are 100% committed to being integrated. It isn't, one of the things is, this is not a government problem to solve. It's a community issue that we have to address, right? And so as a community, that means us private organizations, if we can have better coordination and we can do things like having a by name list and actually have those reforms were amazing. Did I not tell you he was smart? I told you he was really smart. Those reforms would be amazing. It would allow an organization like ours to be integrated and be able to help people get connected. That's what I want. I got to tell you, I have people in my shelter right now with SMI that I can't get them the help. And I would love to work with a public organization to get them the help they need.
Yeah, I was going to say, to define SMI.
SMI, severe mental illness. Thank you. Sorry.
Right. Aaron, did you want to address the same question?
Yes. So I think from a community perspective, we need leadership to bring the hospital association together with private organizations, particularly those that are serving unhoused individuals. And we need to dedicate ourselves to treating people who are seen the most, but treated the least. And there are some individuals who are very vulnerable, who our system doesn't come to the table for. And if we have our county calling upon the hospital association to meet and come up with a plan for people on this list who have the highest needs, who are cycling, but are not getting the care that they need, I think we would have a much better local society.
Aaron, I wanted to give you an opportunity to respond to one thing that Paul had said. He mentioned care court, and I think one of his main points was just voters expected care court to work one way, but is not working that way here in San Diego County. You actually didn't mention care court much in your presentation. You talked more, especially about 5150 holds and then 5200 holds. I wanted to give you an opportunity to respond to that claim about care court and to see what you thought about it and if it has a place in kind of your overall sense of the solution.
How much time do we have? So care court was billed as a way potentially to get someone connected to a conservatorship if they're failing. That is not the reality. That's not the law that was passed. But the law did explicitly point out the 5200 process. So if someone with a care agreement was not participating in their care agreement, or if someone with a care plan, which we have 0 in our county, as far as I know, if they're not adhering to their care plan, a judge could order a 5200 evaluation. But a judge can only order a 5200 evaluation if the county submits a petition for a 5200 order. And so if the county doesn't submit a petition, the judge doesn't have the authority to make that order. And I highly doubt people who are writing the CARE Act legislation knew that nuance. So the other part, so that's one thing for people whose needs are too severe for folks in the CARE Act program. Hi, Tara. Good to see you. So we're talking a little bit about the CARE Act program. Okay. So the other part of the CARE Act program that I think is particularly problematic is when the CARE Act petition goes to the judge, and if the person is already enrolled in ongoing voluntary treatment, their petition is dismissed. So it's no joke to submit a CARE Act petition. It's multiple pages. And it also involves a behavioral health professional filling out something that's multiple pages. Why would someone go through the trouble of filling it out if someone is already doing well in their ongoing voluntary treatment? But the law currently allows for these petitions to be dismissed. And so for people who are already in an ACT program, assertive community treatment, which is a wraparound intensive case management program, but that's not meeting their needs, and a care court petition is submitted, that petition can be automatically dismissed because the person is already engaged in treatment, despite the fact that that treatment doesn't meet their needs. So it's very problematic. And so that's one of the reasons why I didn't include it in my talk, was because there'd be too many fixes that I would need to recommend, that it would be longer than 10 minutes just for care court alone.
Right. And Tara, we will give you an opportunity for your 10 minutes, but I just wanted to give Paul an opportunity to respond to what Aaron said about her.
Thank you.
Yeah, right. So again, though, here becomes, this is and you mentioned like the hospital association. Again, we got to start using these tools. I love, really smart guy. He's in the behavioral health side. I'm on the homeless service side. In other words, also I could say the community side. Fine, I'm willing to adjust, but we got to get this information out to us. Those of us who are doing the work on the opposite side of the behavioral health line, we need this information so we know how to advocate, so that we know what we need to pull. Here's a reality too with the hospital association. We missed an opportunity. I want to say it was either 17, 18, or 19. We passed a law that said hospitals say what happened to people who get discharged, where they had to provide them with food and access to shelter. What an incredible opportunity to coordinate with the homeless service system. Guess what we didn't do? Coordinate with the homeless service system. I was at meetings and there was an opportunity. And again, but we in San Diego, we love to miss our opportunities. And we missed that opportunity. Yeah. Again, it's like, and so we have these things, but man, all we need to do is turn the knob a little bit and we could actually go really far and really actually require. And we got to break the line. I think he's smart. I think he's right about a lot of things. I want to work with him. I have a system that keeps me from working with him effectively. And the only people getting harmed are the people on the street.
So we'll pause the debate for a second, and we are joined by Tara Stamos-Buesig, the founder and CEO of the San Diego Harm Reduction Coalition, and I want to give her 10 minutes to sort of explain to you guys sort of her solution to this issue, and then we'll fold her into the conversation. So Tara, you have 10 minutes and the floor is yours.
Okay, I don't have slides for you guys. What I'm going to bring to you is a little bit different. My name is Tara Stamos. I want to first of all thank Voice of San Diego for this opportunity and apologize for being late. I've been all week up in the Bay Area at a conference and my flights back home were delayed and messed up. So I'm just squeezing right in here. I'm going to present a solution that will require you to think a little bit outside the box today, and one that will provide you with real and tangible solutions that are actionable. I know that I'm here because I want to see something different going on in my community. I have a lot of people I work with on the streets that are left behind, and so I want to give you each and every one of you that are here today an actionable item to take home with you, so that we can be the change that we really need to see, at least a part of it. And all of these things, they fall on each of you to be a part of the solution, rather than sitting back and waiting for somebody else or some government entity or some bill to pass or some law to be made in effect. That rather these solutions are they're not instead of, they're in addition to or along the spectrum of, and they are those small acts of kindness. They are the radical acts of love that each and every individual that I work with on the streets, which has numbered in about the 10 to 20,000 range of individuals that access our program. And I have relationships with a good number of those people by name. So I'm here to speak truth to their voice and give you an idea about what people out there are actually themselves are needing and wanting it. And I ask you to ask yourself, why is it that we think there's a problem in the first place? And is it because of the optics? Is it because of we pay tax dollars and we should have better? Is it because we we are buying into a system that wasn't meant to support people in the first place. And we have to look at systems as part of the problem and as systems as a way to address the problem. And so that we can work within the parameters that we have available to us to provide services to people that really need them. Obviously, for the last 30 or 40 years, we've been doing it as much as we know to do. When we know how to do it, we do it. But something's not working. Something's missing, and I'll tell you what that is. And that is individual. I might get emotional. Sorry. That is that one-on-one interaction that we have with people. We far too often leave people behind, and they are forgotten. They are stigmatized. They are judged. They are left behind. And the solution that I have found over and over and over again to uplift individuals out of that space is to stop and to get to know those people, to stop for each one of us to adopt an idea or a thought process of, if this is somebody's child, this is somebody's sister, somebody's brother, somebody's aunt, somebody's uncle, somebody's friend. And I don't know about you all. Raise your hand if you are a couple paychecks away from losing, you would not have your housing. Raise your hand if you are a couple paychecks away from losing housing. Well, there's a good bunch of privileged individuals in this room, and that's good to see. But for a lot of us, including myself, it's a paycheck or two away from no longer having housing. And we live in a place that it's a privilege to have even a studio for under a couple $1,000s. And I don't know how many of you have gone out into the job market lately, but finding a job that's going to be able to support that's really difficult. And we rely upon our governments and our systems to be able to support other housing opportunities and treatment opportunities for people, but we leave that all in their hands. Though we don't take any personal responsibility. We look at the individuals that we are out there serving as these issues being individual liabilities rather than the community responsibility. And we need to start showing up for our people a lot better, whether that's your kid, whether that is a neighbor, whether that is just somebody you're walking by the streets. I'm asking you to please stop walking by people. Stop and ask them who they are. See them. Because I was them. I was them. I was homeless for 25 years. Off and on, I was a sex worker. I went to prison. I lost my kids. I did a whole lot of things. And I exited that lifestyle because somebody saw me. Somebody saw me. It didn't matter that I'd been through every treatment program in the county of San Diego at the time. It didn't matter that I had been incarcerated. It didn't matter that I had had Prop 36. It didn't matter all those things. They helped. But what really mattered and made a difference for me in 2013, so that's a while ago, is somebody stopping and asking me about hiking. They saw me as somebody other than a person who had issues with substance use or housing. They saw me for who I was because I was forgetting who I was. And so many folks that are out there, they don't remember their why. They don't remember that they're worth so much more than we give them credit for, and they deserve dignity and respect. And I'm sure I missed you guys' thing, and I'm sure that both of those have their best solutions. But we have to start thinking about getting people to even to that spot in the first place. Because I know, for me, just between the airport and here, I ran into a number of individuals that I had a hard time driving by because they're people who I serve, and I'm their only lifeline. Harm reduction provides a space for individuals that I'm the last line of defense for folks on the streets. I'm often out 7 days a week, solo by myself, with a 4.5 foot tall Milwaukee pack out cart, 200 pounds full of supplies, and a whole lot of hope. And I hug up on people, I love up on people, and I ask them all day long, what is it that you need today to help you to get where you're going that you're not already getting? And how can I help you to get that so that you can take that next step to move forward? And it's really sometimes we tell people they need to do this and they need to do that, but it's oftentimes having somebody walk with the person through the thing. For the workforce that we have out there has not been adequate at all in addressing this issue. I talk to people every single day on the streets, and they don't have a worker. They don't know who their worker is. Their worker has changed, and they're having very little success for the most part in actually making the changes that we would hope to see in an individual. We get them into housing, but then what? Are we supporting them in educational endeavors or in career development or preparing them to be able to afford housing on their own, minus the programs? I see so many people return back to the streets after a short period of time within housing, and they become failures. And they're not failures though. But I don't know how close to my 10 minutes I am, but my solution is really one.
5 minutes to go.
My solution is one that, I was in Bogota a few months ago, and they have a great thing. There's 11 million people in Bogota, so it's doable here. But they have a neighborhood house in every single neighborhood. There are 8 to 12 neighborhoods in every barrio. And so if you think about that as like maybe a downtown area, and downtown has a bunch of little other neighborhoods within it. Downtown might be the barrio, and each neighborhood, Little Italy and such, would be the neighborhoods. And each neighborhood has a house, and that house is where they do. They cook together. They have art shows together. They sit and watch TV together. They create videos together. They break bread together. The people that live in the neighborhoods come back. The doctors in those neighborhoods come and provide several hours of services into that same communities. The youth go back to school. When they go off to college, they bring the work back there, and so they're going to school to be doctors and bring getting PhDs and bringing their stuff back. The youth aren't left to struggle on the streets because they have a place to showcase whatever it is their hobbies and be supported. And I know that's not super replicable here in San Diego or in any area in any large scale, but it's really thinking about bringing it closer to home. So I've always had this theory that if every block, you picture a block of houses, if every block were to adopt one person, and that block has somebody on there that's got somebody who's got a room for rent, somebody else has an old car that they needs fixing up, but it'll run. Somebody else has leftovers every night because their oldest kid went off to school and they'd be happy to give them to somebody. Somebody else has a print shop. They need somebody to sweep out front of every weekend. But every little bit we pitch in and we provide a community. We mentor individuals. You cannot expect people to get with the program and to do all these things without mentoring them up. Some people don't know or they don't remember. And often, what I'm seeing with people who have experienced overdose is they have cognitive stuff going on, and it's going to be really difficult for them moving forward through both of your systems. It's going to be hard. We need to learn how to live up on people. Overdose deaths have taken 83 of my friends. And I see so many other folks that that I work with that have experienced overdose after overdose after overdose, and that's real shit. Or, sorry, that's real stuff. And I see a lot of people that I've worked with for a long time just not get it anymore. And it's not so much of a behavioral thing. It is. I mean, it shows up like that, right? But it's a lot of stuff I see is cognitive, where people are, it's a frontal lobe injury, and so they're higher risk takers, and they're not able to think about their future as much. There's a lot more like invincibility, and it's like dealing with a teenager or a young kid, a prepubescent kid, and so we have to take a look at that stuff too. We have to take a look at the whole person. They are a substance user. Yes. They have mental health issues. Maybe, sure. Who wouldn't at this point in life in this game that we're in today? I don't know. But I mean, we're living in a really rough world. I know you guys are all probably housed here, and you have the news, and whatever side of the aisle you fall on, it doesn't really matter. But you see that things are all over the place, and we have the ability to sort through them and to take in different perspectives, but the people out there don't. And I know that what the people on the streets, the people that we are addressing here, number one, they belong at the table to even have this conversation, to be able to say, this is what we need. This is what we need. This is what will work for us. And I ask people all day long, what worked for you before? And they tell me, and I say, cool, let's do more of that. And then I ask them what didn't work for them, and they tell me, and I tell them, then let's not do any more of that. And I, no offense, but involuntary forced treatment has never been a successful thing. If you look at research across the board, it has never, ever, ever been a long-term successful thing. You cannot shame and punish somebody into a behavior change that's going to be intrinsic. It needs to come from inside, and that's an external like stressor, and it breaks a lot of people. And I also am a person who changed my life because of Prop 36. I was sent to jail and I had that break. And so I have a lot of views around that. We need to have it as one of our tools in our tool belt. We need to have all of these things so that we can address people across the spectrum and not leave anybody behind. And so whether it is changing laws and bills, and I have, I think, 13 bills under my belt at the state level for different things involving substance use and mental health and harm reduction and HIV and Hep C. And those are all things we need to work on. But today, when we leave here today, the solution that will get us closest to really seeing a change in our community is all y'all actually stopping and taking a minute to ask somebody who they are. Come back the next day or the next week, bring them a sandwich, have a conversation with them, find out what their dog's name is and bring it some dog bones next time you drive by. Stop and see people, ask them who they are, because what we need today, no matter what we're looking at, is a whole lot more humanity. We need to remember that we heal in community. We heal when we're seen. We heal when we feel safe and when we feel loved. So I implore upon you each to find somewhere within you to find like the radical act of love. There's no program you can write that into. So if you're a policymaker or you're a stakeholder in the community, think about ways you can have a little bit of flexibility in your policies and procedures and stuff so that the people that work for you don't struggle with burnout as much as they do. Because
All right, that's about time there.
Sorry, that's all. Thank you.
So pivoting off that, Paul and Aaron, I want to ask both of you, because I feel like Tara basically raised a basic issue. She mentioned that compulsory treatment, which both of you talked about in different ways, being your brother's keeper, making that decision for someone else, 5150 holds, 5200 procedures. The forced treatment doesn't work. And just the basic act of making a big decision like that for somebody else could really be a violation of their personhood and their autonomy. I wanted to give you both an opportunity to respond to that.
Yeah, I think a couple of things is, again, and I loved what you said. It's our responsibility, right? We all do have a role to play in that, and super heartbreaking that some of the people you work with don't know that are outreach workers, right? Actually, the RTFH did an incredible job. Ian DeJong, if you guys see him talk, he helped our community develop the standards around street case management. And we have it. And as a homeless service provider, please hold us accountable. The outreach workers should know. And this is a combination, right? This is where it needs both community loving people, and we need professionals engaging with people. And we need our professionals, including our outreach workers. I thought Ian did a great job of talking about, hey, big heart doesn't equal a big mind. One of the things we stress, and yes, I'm a faith-based organization. We tell our team, I want you to have the heart and mind of Christ. In other words, I want you to love people well, but I also want you to be a fierce professional. And we're going to know what we're doing, and we're going to use wisdom. And so that's why when we actually think of it from a communal perspective, if I have an outreach worker doing the community standards, actually following them, getting to know the person, building the relationship, then able to bring in clinical help as needed to help evaluate. And then we have community members showing love and compassion, right? I'm building the pieces together of a puzzle so that if there is that case where the person unfortunately does reach a cognitive level where they are now not able to care for themselves, we actually have a community that loves them, professional homeless service providers that are caring for them, clinicians that are working with them, and now we can make a decision as a community that can help that person stay alive and safe.
Aaron?
So I think this is a very fundamental question that Terry, that you're raising. And it's true sometimes that involuntary treatment can lead to trauma. It's true that we need to make sure that we uphold and uplift people's autonomy. And it's also true what you said about people's cognition being severely impaired. It's also true seeing people who are unable to provide for their basic needs. And as a society, it's our job to answer, what do we do in these situations? Do we look at autonomy only, autonomy till death, and neglect to intervene in cases where someone clearly needs help? I don't want to look at this as either voluntary or involuntary. It's a continuum. And we need to make sure that we look out for people who need our help the most. And too often I see people getting dismissed from hospital settings, from treatment settings, because they're unwilling, or it's their right to make that decision, or they have the right to make a bad decision. But underneath that is a person whose cognition is severely impaired. And oftentimes these are split. And so what's been shown is that when you're having someone in an involuntary treatment setting, what's most important is the environment. And when people feel like they're in a prison environment, they don't like it. When people are given love, compassion, concern, they don't have the same negative feeling. So when we're treating anyone in an involuntary setting, we need to look at at the way we're treating people. We need to make sure that if we have someone on a conservatorship, everyone on a conservatorship needs to have an individualized treatment plan that's tailored to them. It separates what happened in the before the 60s in asylums, what happened with people who were basically warehoused. We should never go back to a time like that. Anyone who's on a conservatorship should have an individualized treatment plan that's tailored to their need, so that we can reduce or eliminate their grave disability and transition them to a place of maximal independence. But that doesn't mean independence only. We need to acknowledge that some people need our support.
Tara, I want to give you an opportunity to to answer a question related to that, which is, are there situations in which you think it is appropriate for someone else to make the decision about treatment?
I think if it comes to that point where you're having to make a decision for somebody as to where they're going to go or what they're going to do, how effective is whatever it is you're going to provide for them going to soak in if they can't absorb, if they are unable to make these decisions for themselves? How much are they able to decide for themselves what it is they're even engaging in? That's one component of it. And I think that there are times when like those few times that there are. My concern is that, and what evidence and research shows is that we rank people through these systems, and they go through their involuntary thing. And if it's truly like all sorts of cognitive stuff, we can't really heal that. Number one, that's something that no matter programming is going to fix. That's something we have to learn to live with differently. An individual who's had it's like a traumatic brain injury, and it's a different type of care that individual may need. But in the most part, to rehabilitate somebody, like, what is our long-term goal? Are we planning to rehabilitate them and they will go back out into the streets and be good forever? Or are they going to go back into the streets and face greater risks of overdose? The individuals who've been in involuntary treatment or any kind of treatment, their risk of overdose is greatly increased upon exit of these things, because it's not, I totally believe that if it is the setting that makes a big difference, it's the people who are providing that care. My concern is that it's taken out of this tool that we have available to us is abused or used in ways that are penalizing and punishing people, and in an effort to get the optics of them out of the way because we don't like it, or society doesn't like them there, and this person and that person and everybody, because the assessment tools that we have, like we've sat in meetings, and my concern has always been, according to those assessment tools, I could be 5150 just for being me, and a lot of the stuff, just because I have these certain things, I have a history of drug use, I have these things, and those can be used against a person. And so I have a lot of concerns around it, and I don't think that we've thought it out completely, but I understand also, right, as a parent, like that that need for those extreme tools, because there are times we need it. I think we just have to be really careful how we usher these things forward. I really do.
Yeah, Paul and Aaron, I want to give you guys a chance to respond to that. Paul first.
Yeah, I mean, and one, I just want to honor and acknowledge your lived experience and how critically important that is. I'm super thankful our director of outreach and our director for our North County outreach both have lived experience, and that's incredibly important. And that's how we balance it out, is that's why it is a community issue. That's why we do have to get everyone. I love what Aaron said, right? We can't go back. We all saw one flew over the cuckoo's nest. No. I would actually offer we should probably go to our skilled nursing facilities where our aged population is. What are the conditions we have them in right now?
Yeah.
And so we do need to seriously go, this is a community issue. And when we make a decision as a community, we do better, right? We do better. I like whether you want to go fast, go alone. If you want to go far, go together. Indian proverb. And so I think that's something where we need to be thinking through how we get those safeguards in place.
Yep. And I think, Tara, what you're saying about making sure that whatever treatment we offer the person really fits with their need is so important.
Yeah.
Because we also know that people whose cognition is impaired are the people who are least likely to complete residential treatment. So if we only offer one solution for somebody with a severe substance use disorder, and that person is cognitively impaired, are we setting that person up to fail and continue to cycle through the street? And that person may not also benefit from someone who's 40 at a skilled nursing facility is terrible. And so what do we do as a society? And I think that's what we've grappled with and what we've struggled to really reconcile over the last several decades of what do we do with someone who is unable to care for themselves due to a severe substance use disorder and is cycling in and out of our emergency departments and jails. And what we do know is that the status quo isn't working. We need to do something different. And I think it's sad,
I just wanted to bring up an issue that I think is latent in what all of you guys were saying. In my reporting on this issue, I often hear that a refusal of treatment, what that really means is a refusal of the treatment that is, or as it may be, is not available. Sometimes people have gone through treatment and they've had a bad experience, and either the treatment they need is not available at the time that they need it because the system is fickle, it's not affordable for people without private insurance, or it's low quality. So you guys have talked about sort of changing the mechanisms by which people are forced into treatment, but I wanted you to address the issue of lack of capacity in the system.
Can I say something about that on that?
Yeah.
I want to say that I think one of the ways that we can address that and a lot of other things is through changing some of the funding source, the ways that it's rolled out, and offering smaller community grants to programs and individuals within the community that maybe have a home that they could open up to do this thing, or have a workshop that they want to, a way to bring small amounts of people in. Just, I think providing those sorts of things in the community as a solution, because I know there are a number of churches and other places that would love to be able to provide some stuff that they don't have. So some of those types of things would be ideal to be able to sort of help. We need to think outside the box, coming up with what do we have already to start with, and really making sure that we ask the people, tailoring to them, looking at how we assess things and what's available for things. But I think we need to tailor a little bit better into individuals and really listen to what they have to say.
Mm-hmm.
So, do you think this is why I said a dynamic by name list? That actually gets right ahead of that issue, because we're actually coordinating all our efforts and we're going, who's the top 10 people in San Diego, so that we can tailor to those people. And here's the thing, every time I get a number one person off the list, I'm saving a lot of money and I make it easier. I reduce the burden on the entire system. A by name list is something we could do today that would have an immediate impact in managing resources, limited resources. The second thing is, let's not miss out on the opportunity of CalAIM. So this is Medi-Cal's ability to integrate the medical system into the community-based organizations. We're doing a job in San Diego. And we have way too many for-profit companies coming in and sucking up those Medi-Cal dollars when it's intended for organizations such as ours. The whole point of Medi-Cal, and I got it, Medi-Cal has its issues. Our healthcare system has its issues, but at least they do coordinated care way better than the home of service system. And so if we actually leaned in a little bit more on CalAIM, what we would do is get better integration to the healthcare system. And then if we're using a by name list, we're going to prioritize our limited resources and actually get people connected more effectively.
So we need a centralized, coordinated system of care for people with severe substance use disorders. We don't have that. And we can do better than giving somebody a piece of paper and saying, call this, call these list of numbers and, you demonstrate your need by how many times a day you call. We can do better than that. We have a system, for instance, in the hospital, if we need to get somebody to a nursing facility, there's a central database that sends out referrals to all the nursing facilities in the area. We don't have that for residential facilities. We don't have that for withdrawal management facilities in our county. We have a piece of paper and we don't have a system that's built out. So that would be the number one thing that I would recommend. I mentioned intensive case management ACT teams. Currently it's an option for counties to deliver assertive community treatment for people where their primary need is because of a severe substance use disorder. My belief is that we need to avoid involuntary treatment as much as possible. But when we don't have assertive community treatment for people with severe substance use disorders alone, then we're leaning more heavily on the involuntary side. So we need to expand the treatment offerings for people with severe substance use disorders. And that is going to require with our BH Connect, it's a state waiver. There may need to be changes that happen from a state level on that, but that is something that's available to counties now with the Behavioral Health Services Act, is that counties have the option of providing assertive community treatment for people with severe substance use disorders alone, and we should operationalize that so that involuntary treatment becomes the last option, not necessarily the only option for people with severe substance use disorders who are unable to provide for their basic needs.
I think also having a centralized, like a drug user health hub is a space that people can self-refer to, because we have to remember that there's a spectrum of stages of change that individuals are in, and maybe they're in pre-contemplation about their housing, but they're in preparation for their hepatitis C to be addressed. And so getting those low-hanging fruit addressed for individuals so that we can start to scaffold that momentum of success and really uplift an individual, and they're all individualized. But what I hear over and over again from individuals on the streets is that I don't have the ability to self-refer into this thing or that thing. And if I could choose when I could go in this or choose which program I went in, I would do it right away. But it's these systems that are navigating, which are nabbing up a lot of the money that could be utilized to house individuals in different ways, whether that looks like more roommate funding for people to be able to rent a room from somebody. There's all these different restrictions on funding, and we have to, even as individuals who are housed, it's hard to find housing in San Diego, period. And so being a little bit more flexible with how we spend the voucher dollars so that people with severe substance use disorder are able to access things. And then I also think that we need to take a moment to think about, why are people ending up with severe substance use disorder in the first place, so that we can stop having to throw these resources that way. And that thing that is killing my friends and people out there that we love and care about is stigma. It is isolation. It is judgment, and it is the criminalization of a whole lot of people, and it's not getting it any better right now. And we really need to think about moving forward how we can lessen the amounts of trauma that we provide. We unintentionally, I hope, impose on other people, and look to ways. And that's one of the things that, like, just loving up on your community, whether that's loving your kid a little bit more or loving your neighbor a little bit more, or the people, but please take some time to go out and love on the people on the street, so that we can, moving forward, we don't have to have these conversations as often as we are right now.
So we are going to pivot to questions from the audience in just a sec. I wanted to do one lightning round for each of you, because I feel like implicit in all of this I'm hearing a lot of, there's a lack of leadership, a lack of coordination. Somebody in this county or some agency is not stepping up and exercising leadership and coordination that they should. So I'd like each of you to give like a one-word answer, pick one, and say, the County of San Diego, the Behavioral Health Services, or Tara, maybe you just would want to say people themselves, but you can only pick one. Just say it, and you don't have to explain why. I just kind of want to hear you, name some names. Go for it.
County of San Diego.
Okay.
Board of Supervisors need to lead our county bureaucracy.
Okay. And Tara?
I'm going to say the County of San Diego. I'm, as an individual who got to, that's it. I'll say that.
All right, so we are going to pivot now to questions from the audience, but first, we are going to have our first question today will be asked by our Aaron Price Fellows. Yeah, you're here, right? Yes. Come on up. Okay. Each year, the Aaron Price Fellows Program selects 40 kind, inquisitive, open-minded ninth graders from a pool of 300 applicants for a 3-year journey. They go behind the scenes to see how cities function, explore the role of community members in shaping society, and develop empathy and skills for navigating a diverse world. The program is a high school leadership experience started in 1991 by the Price family, the founders of Price Club. And the mission of Aaron Price Fellows Program is to prepare a highly motivated and diverse group of San Diego public high school students to be responsible, engaged, and caring members of their community. So please, let's have a round of applause for our Price Fellows.
Good afternoon. My name is Radia Chowdhury. I go to University City High School. I'm a sophomore, class of 2028, and I have a question. People who experience problems with their behavioral health often refuse treatment because they are afraid of feeling invalid, unheard, and unseen. What are ways the city can help destigmatize receiving behavioral health assistance?
Okay, I think first it is we do need to elevate lived experience. So I'm also happen to be a veteran. And I'm going to tell you what helped with young Marines and sailors. So I had the opportunity to serve both Navy and Marine Corps, was when a colonel or a senior enlisted guy stood up and said, I had to get help. One, I had to take medication. And so I do think valuing lived experience, and then those who are in leadership, the more transparent they can be, game changer. It really is helpful. If Supervisor Desmond said, you know what, I actually take antidepressants. He doesn't. I'm just kind of going to see it. No, but with all seriousness, that destigmatizes when people in leadership are willing to say, hey, I needed to get help. And then we elevate lived experience so people can see, hey, it's okay. Like, yeah, we all have experiences, and we value people with lived experience. I think we can do a lot to destigmatize. Thank you for that question.
So to that point, I've been treated for depression. I've been treated for alcohol use disorder. I think that it's very important that we acknowledge that we all struggle and that we all need help sometimes, and that we're all interdependent upon each other. And we need to acknowledge that as a society, we need to look out for each other. And so when Paul was talking about this hyper individualistic culture, I think we've elevated autonomy to the extreme, and we need to do much more about looking out for our brothers and sisters.
I think addressing, we look at systems, there's high school students and such, and that's really where we need to start, because we need to normalize accessing services in the first place. We need to talk about where and how to access those services, because what I see far too often is people graduate or end their educational career or exit, whatever that is. They turn 18 and they're left without any support to navigate. They don't know where to start. They don't know that it's, they're trying to figure it all out. They may not even be able to identify that that's that's what's going on with them, because they haven't really been given any framework, and people are afraid that, oh, because we get out into the world and it's this big bad world, and it's, we don't want to be like them. And so we may find ourselves having a hard time. And so how do we fix that, is to have the city and the county and other funders support programs that are bringing in our youth, that are telling them, like, everyone's messed up today, and in one form or another. We may not be messed up in the same way, but it's okay. It's okay. It's okay. We're going to be okay. We need to tell each other that a lot more. It's going to be okay. And just messaging to the youth is, I think, one of the biggest ways that we can ensure that we provide a pathway for people, and the okay for them to do so, because we don't want people to deny who they really are, or what their experiences are. So.
So I'll pose a question from the audience. I saw this question several times in the ones submitted. Given that 5150 hold, which several of you referenced, really only lasts for 72 hours, what can realistically be accomplished with such a mechanism, and what typically are the outcomes?
So imagine if we had a dynamic by name list with care coordination. It gives us time. And if we actually are integrated and coordinated, it allows for a handoff. I do like some of the crisis response. There's some things out there, but we have to do the coordination and do the handoff. That gives us, yes, it's a brief moment of time, but if a brief moment of time, we can coordinate our efforts, we can actually get them handed off to the next right place.
And a 72-hour hold should be an opportunity for an intervention. It shouldn't be a 72-second hold. It shouldn't be an opportunity for an emergency department physician or staff person to see that 5150, write a big X through it as the person is walking in, so the person is then immediately discharged. We can do so much better in our system, and 72-hour holds should be looked at as an opportunity for an intervention so that it doesn't happen again, versus something that needs to be dismissed expediently. I think we need to look at this violation of someone's rights as an opportunity and a call to duty.
I think that with the 5150 holds after that 72 hours, we are seeing so many people who are just cycling right back through over and over and over and over and over again. And oftentimes those 72-hour holds are placed by individuals who are tired of picking up that individual, not because they have an issue that is unable to be addressed, but just because of the optics of it. And I think really following up with individuals to make sure they actually get that warm handoff, because far too often that actual handoff of sitting with a person from the tail end of their 72-hour hold until they go to this other treatment provider, and then sitting with them and explaining them, because they were in a 72-hour hold where hopefully they've had time to balance out, to get a little bit of homeostasis going on, to have, we're addressing all sorts of things. They were in deep crisis. And so we've just got to let that crisis calm down, and to expect them to jump into services and be on board with everything is a lot. And so really having some gentle working with the individuals in that post 72-hour stuff, instead of being like, we're sticking you here. Those places feel really punitive to people, and that makes them afraid. So that would be my thought.
I have one additional point. We also need to make sure that treatment options are available from the ED. Mm-hmm. And so often it's, here's a piece of paper, make a phone call, and there's no linkage from the ED. And this is the responsibility of the county to make sure that there are robust treatment options from the emergency department that we can directly link someone to, that we can confirm that they're linked, so that we stop this cycle. Because too often it's just a piece of paper.
And having a drug user hub type of a place that people, it would be the catching spot for individuals coming out of 5150 holds or getting ready to go into detoxes or whatever, that kind of in between, before, after space, that is where we lose so many people. Having just a space for people to access services that is less pressured upon them and more welcoming and staffed by people who can really help them to navigate that space, I think would be a huge. I've traveled the world and visited all sorts of different models, and I will tell you that it is in that space that offers those like different things. In Canada, they do this thing called Daytox, where it's 60 different sessions or days that you get stacked up together. You can spread them out however, and you have a menu list of options for what it is you need for treatment, whether it's yoga, hiking, psychiatric care, but you pick them as you go, and you yourself tailor your treatment as you need it, and the success rates are phenomenal. And while we may not be able to replicate that, but giving people a little bit more autonomy in what they need at the time and how they can access it, I think would be great. But that would require the county to do a lot of opening up, and seeing as how they've been canceling a lot of things. It's I don't know,
A lot of our conversation is centered on people with substance use issues. But here's a question, can or should we force severely mentally ill people to take and stay on their medications?
I'll take it. Right. This is about the autonomy issue. I think this is it, and we got to be super careful. But as my example, we won't force them to take their medication and they'll sit in jail. That's happening right now, right? That's a reality of an individual that our outreach workers have worked with, which we know medication. And in fact, we've seen when that person has taken medication, we've actually moved forward. Now, we want to protect autonomy, but when they're in jail, they lose all autonomy. And that's our tension point that we got to figure it out. We got to regulate so that if we are requiring medication, we have safeguards. We're doing it humanely. We're thinking about their environment. All of those are true, but knowing if we don't require it, be okay with us continuing to lead the world, our industrialized nations with the highest incarceration rate. So your choice, which one do you want to do? Do we want to figure it out, or do we want to continue to allow our jail system to be our primary behavioral health provider?
To that point, so Governor Newsom signed Senate Bill 820 on Friday. Senate Bill 820 is for now people with misdemeanors who are found incompetent to stand trial and are found severely mentally ill and lack the capacity or the understanding to consent to antipsychotic medication. Now, people with those characteristics can be found to lack the capacity for antipsychotic treatment. It can have medications administered over their objection in jail settings so they can participate in their trial. And this, again, is where people who have been excluded from the system end up. There is a system, it's our jail system, and we need to move away from that. Now, currently in inpatient psychiatric settings, the only way you could administer antipsychotic treatment over objection is in an emergency or through an additional court process where the person is found to lack the understanding of the need for antipsychotic treatment. The only other option is on a conservatorship. And so when people are in the community on a conservatorship, they can be required to take medication, but outside of that, currently now it's in jail.
I'm going to say that probably something that might not be favored by everybody, but some people like their crazy. And what we see is they're crazy is maybe they're brilliant. Madness is genius, and I'm a genius. And sometimes I feel mad. I have some thing of that. And I think allowing spaces for individuals to make creative, to have creative and intentional communities. So where it's a spaces for individuals who may be on the spectrum or may live with neurodivergence or ADHD. Like my ADHD is off the charts, and if but by some people, that might be a thing at some point that I could be forced to take medication for. And I have taken medication for in the past, and it has squished who I am, and it has taken away from me my ability to feel. And I have been on antidepressant medication, and it has worked for me. But there's other medications I've been on that have absolutely, I felt like a hostage in my own body. And I think that's the part that's in autonomy, is like that we have to look at it. Why are we deciding if somebody else is experiencing life in a different way than we are? Are we just expecting everybody to get with the program so that we can live more comfortably because that doesn't look good over there and I don't understand that thing? But maybe those same individuals are over there saying like, I don't know what's wrong with those people because they're all living life this other way, but we're not experiencing what they're making us do. So I think we have to take a look at who's making these decisions, why they're making these decisions, and if these decisions allow for an individual to be truly who they are. Because if we are telling people, if you show up as you truly are, you're going to end up this way, then how can we expect people to actually get the treatment that they need and make the changes that they want to make if they're having to lie about who they are to be safe in the long run? You know, it's a hard one. It really is. But some people do, like, they're the way that they present may not be comfortable for all of us, but they may not be actually problematic. It may just be the individual lives differently and we just aren't understanding why they operate that way. And that might require us to look a little bit deeper.
Well, I think this has been a great discussion. We're going to transition to voting, but first, I just want everyone to give a round of applause to our